For joining us for today's ACNM SNMMI webinar, Evaluation for Post-Renal Obstruction. I would now like to turn it over to Dr. Twyla Bartell that will introduce today's webinar speaker.
Thank you, Delisha. We are very pleased to have Dr. Mark Tolchinsky present this talk on renal scintigraphy. Dr. Tolchinsky has been practicing and teaching nuclear medicine at premier academic institutions for the past 33 years. He has achieved the academic rank of tenured full professor of radiology and medicine at Penn State University. His clinical practice includes all of the FDA-approved diagnostic nuclear medicine tests, for example, bone scans, myocardial perfusion imaging, and PET-CT, to name a few, bone densitometry, and radiopharmaceutical therapies. He regularly organizes and also presents at national and international specialty meetings. He has published his clinical observations and results of clinical research. In fact, he's had over 100 articles published in peer-reviewed journals. He also has contributed to 10 book chapters. His academic and advocacy outreach are realized through his leadership at the Society of Nuclear Medicine and Molecular Imaging, or SNMMI, and also the American College of Nuclear Medicine, or ACNM. He is a fellow of both organizations, and he is currently the president of ACNM. He advocates also for nuclear medicine at larger organizations to include the American Medical Association and the American College of Radiology. So thank you so much, Dr. Tolchinsky, for giving this talk for all of us.
Thank you very much, Twyla, for this kind introduction. With that, and no further ado, we're going to go straight into the subject. And the subject indeed is post-renal obstruction as part of the nephrurology, as we offer some very pivotal evaluations, particularly the renal scintigraphy with diuresis. There is some historic perspective that is worth keeping in mind, and that is it's only in 1926, less than 100 years ago, that Molière and his co-author suggested the concept of renal clearance. Subsequently followed in 1945, at the end of the World War II, Homer Smith refined it by defining a term of effective renal plasma flow, or ERPF, as some of us know it, which is the fraction of the plasma flow available to the glomeruli, functional units, and the tubules, another part of functional unit. In 1952, Oser and Billion were the first to use the radiopharmaceutical. I'll be abbreviating here as RP. It was Iopax, labeled with iodide, radioactive iodide, to measure the renal clearance. Then they collected the actual urine and measured it in the well counter for activity. So that was not scanning yet, of course. And in 1960, Tubicinol published their preparation and use of the first renal plasma flow agent. And that was the radiopharmaceutical called I-131, iodohypurate, OIH. Now, you can also imagine that the first activity measurements were not really with an imaging system, but were with dual probe system. In fact, Netter's atlas gives that first drawing of what it used to look like. And this complex apparatus was essentially able to plot out the raw counts, raw activity as detected by two, what we would call today, thyroid probes. So then, what takes into measuring function with radiopharmaceuticals? Substances in circulation that are cleared by kidneys can be eliminated by one of two ways, either by glomerular filtration or by tubular secretion. So filtration is a bit more of a passive process driven by transmembrane pressure within the glomerulus, while tubular secretion is an active process and really takes ATP and other metabolic processes to see it happen. Glomerular filtration rate reflects the rate of removal of filtered substance from plasma. So that's a GFR, or the rate of filtrate formation. While the GFR ideally is measured using freely filtered compounds that is not reabsorbed nor is it secreted by tubular cells, the example of which would be DTPA. And we are all familiar, but don't use much of DTPA lately. Now, the ERPF, effective renal plasma flow, is ideally measured by a tracer that is completely cleared. And that would include cleared by the GFR and tubular secretion by both on its first pass through the kidney. Example would be orthoiodohyperate, or estimated by partially cleared tracer, which would be one of the examples we do use every day, and that is MAG3. So MAG3, unlike hyperate, is not completely cleared. Only 60% is cleared, while hyperate is nearly 100% is cleared. And you're all familiar, obviously, with the normal renal anatomy and function. I'm not going to dwell on that, only to make sure that you keep in mind that the renal medulla is right below the cortex. Within that, you see the papilla, as well as you see the renal pyramids, and then it all drains into the renal pelvis. We're going to take a snapshot of that, and you know that there are arcuate arteries and also the straight intertubular arteries, out of which we find formation of glomeruli. Now, let's dive a little bit deeper here so that we understand where each radiopharmaceutical actually works. So you will see the red line, and that separates horizontally cortex from medulla. Now, you got your abbreviations on your right-hand side, DTPA, EDTA, glucoheptanate GH, that you probably have not heard much about lately because it's been off the market, but you certainly are familiar with MAG3, and some of you still remember orthoiodohyperate. So then, they will also be highlighted for you in functional classes. Those who have glomerular filtration as their most significant method of clearance. Tubular secretion is in green. Tubular fixation, when you're just looking at the cortical integrity, not so much renal plasma flow or filtration. And then some are multifunctional. So, of course, glomerular filtration, already been mentioned, can be assessed by DTPA, and that's labeled with technetium 99M, EDTA with creatinine, or iothalamate with iodine 125 for those who would like to measure GFR using blood counting techniques. And that's also available. Now, so that is all happening in glomerulus. What about MAG3, the most commonly used radiopharmaceutical in the United States? Well, that's happening in a proximal tubule, and that's pointed by those green arrows, as you see. And that will be supplied by the branches coming off of the efferent side of glomeruli, and then wrapping around the proximal tubules. So in green is MAG3. Orthoiodohyperate is also filtered just as much as DTPA, but it is also, in addition, actively excreted and secreted by the tubular epithelium. And that's why it's in that brown color here, multifunctional. There are several functions that it represents. And here is a little pearl that you ought to keep in mind going forward. And that is at the same very site is where you see the clearance of Lasix. The way Lasix works, it's a loop diuretic, but it's cleared by secretion, tubular secretion, into the proximal loop of Henle, and that is where it does its work. So indeed, if you think about it, the uptake of MAG3 would be identical if you were labeled Lasix with the radioisotope. You would see exactly the same extraction and uptake in the tubular epithelium as you do with MAG3. So to say it maybe a little differently, if you want to know how much Lasix works in a tubule, you really ought to watch how well MAG3 is taken up, because they will be proportional. Not something you often hear, but there is your pearl to carry home today. That's a take-home message. Then on to the DMSA, dimethyl succinic acid, and that is in the distal tubule, extracted and fixated within the tubular epithelium, and it does not leave. It stays with the patient. The technetium decays, but DMSA stays with the patient fixed for as long as the patient or that tubule is still functioning. And so glucoheptanate not used, we're not going to spend much time. And then the overall renal physiology is you pump about 700 mLs per minute of effective renal plasma flow. That is what gets to the functional side of the kidney. And as you can see, it gets filtered, and then efferent will take it out into the tubule. And if we send along the tracer that's like inulin or irohiperan that's completely cleared, you will see it first go through and filter out, but only 20% will filter out. Now remember that number, 20% is all filtration that you're going to get. And therefore, the cleared by glomerula, that filtration tracer, although it's an excellent radiopharmaceutical and essentially not cleared at all by the tubular secretion, but it can only, at the best of circumstances, show you 20% of overall normal renal function. So it's particularly a poor imaging agent in those with abnormal renal function. Already, and with normal, you only get 20% of what you're injecting going into imaging. And then if you decrease that further by renal dysfunction, you got a really poor tracer for imaging. However, if all you're interested is the functional assessment, that is your person there. That is your agent to use. So minimally protein bound in blood, dosage is about 10 millicuries in adult, and indications are specified. But we don't use it, as I mentioned, because most of what we do is we try to get a good visualization and extraction. So 80% of the tracer that is completely cleared will be cleared in the proximal renal tubule. Very important. So 80%. So 80, much better than 20. And so that's where you would like to put your bet on good imaging. And that would be your MAG3, although it's not an ideal tracer, unlike inulin or orthoiodochyparate, it's only cleared on first pass 60%, while hyparate is nearly 100. So then, as I've stated, about 50 to 60% it's what goes from the MAG3 to add to your imaging characterization. It's 80% protein bound, and that's what most of the secreted agents do. And we use 10 millicuries. Common applications include differential renal function, evaluation for post-renal obstruction, which is where we're going to spend most of our time talking, and evaluation for renovascular hypertension, not so much anymore, with other modalities displacing renal imaging. And then renal transplant evaluation is still used considerably, and for calculation of ERPF. However, clinically, of course, we're more commonly encountering calculations of GFR. So then, MAC3, images initially are acquired at the rate of about 1 to 3 seconds per frame for the blood flow assessment. Those are usually not very consequential, and for what we're doing today, talking about, it's inconsequential altogether. Then images are obtained 15 to 60 seconds per frame, depending on the laboratory. Renal imaging is still quite heterogeneous across the practices within the United States. Standardization has not really done much for renal scintigraphy. And so usually the baseline imaging is acquired over 25 to 30 minutes, depending again on where you practice. Parenchymal uptake occurs between first and fourth minute. That's what's used. The parenchymal uptake phase is what's used for differential function evaluation. And you usually would always correct it by circumferential backgrounds. Some use crescentic backgrounds, but majority for this particular assessment of differential renal function use circumferential backgrounds. And then you generate the time activity curve, and for that you correct by crescentic background region. Let's take a look at the typical case. Here is the blood flow, nothing that striking. You see the activity in the aorta, and then on the next frame, you see the blush in both kidneys. That activity in both kidneys that continues to accumulate while the activity in the aorta washes out within 2 to 3 frames. That is normal. So as soon as you see the aorta, the next frame, you should see the blush in the kidneys, and then that continues to accumulate. So this is 2 seconds per frame imaging. Subsequently here, what we do is a dynamic imaging for first parenchymal phase. And that parenchymal phase, you see the uptake. And remember what I've said, how well MAC3, this is MAC3, what we're looking at, how well MAC3 is taken up by the kidney is how well your Lasix or furosemide will function. So here, your Lasix would function well if you were to need it. Obviously here, we also would look at the subsequent phase, and that's a urodynamic phase as it washes out, and there is near complete, essentially as complete as it gets, washout of the radiopharmaceutical, no need for Lasix. Here I would mention to you that whenever you do administer a pharmaceutical enhancement to your study, mention why you did so, unless it's a absolute routine, such as, and this goes for any nuclear medicine test. So on the parenchymal phase, you would also look at the renal axis orientation. This is normal, closer at the cranial as it diverges out towards the caudal side. You would look at the cortical integrity, which is what I'm showing, but that circumferential areas. So if there are any renal defects, for example, if the patient had reflux nephropathy, you would see cortical defects. You should report those. And then the excretory phase, as we've already described. Subsequently, you would plot out the renal curves and exactly what do we do for the differential function, as I've mentioned, surround the kidneys and do the circumferential regions of interest. And here is your differential function. Differential function is reported in whole numbers. Here you see fractionals, but you see decimal points, I should say. And you usually would report this as 53%, and the right kidney would be 47%. So that all has to be equal 100. You can also get some indices from the curves, like time to peak is one of the important indicators, and we'll talk about that. For this curve, you would do the same region of interest around the kidney, but correcting it by the crescentic background. Because if you do it circumferential, obviously, as the kidney clears the tracer, it'll be passing through here, throwing counts into the background region, would cause a lot of noise. So that's why crescentic. And here's the main information here. So I would suggest to you reviewing this particular article by Steve's out of Dr. Tip Taylor's group. And it's extremely helpful, was published in AJR. And here it gives you all, within that article, all the normal ranges. So they report normal range to be from 42 to 58%. Within the 95% of CI of the normative group. The Tmax, anywhere from 2 to 10 minutes. That's also your normal grouping. Okay, then. We are up to MAC3 renal cortical system dilation, obstruction versus non-obstruction or non-obstructive hydronephrosis. How do we break this down so that we understand exactly how to make that differential? Renal collecting system, RCS, you will see the abbreviation here used. So renal collecting system dilation anatomically is often indistinguishable in obstructive versus non-obstructive causes on anatomical imaging, such as ultrasound, CT, etc. CT gives you some advantage of the contrast clearance if you do give contrast to the patient. But even with that, it is still difficult to separate obstruction versus non-obstructive dilation. Prolonged cortical retention of radiopharmaceutical or delayed cortical transit could be seen in obstruction, but can also be seen in some medical causes. This is what one of them looks like, for example. You see the right kidney on your right-hand side, left kidney on the left. It's a posterior imaging. The times of imaging are mentioned here. This is a baseline dynamic. And you can see that the right kidney continues to accumulate the tracer within the cortex. So, and it's enlarged. This is obstructive pattern. There is no point giving this patient Lasix at the end of this imaging sequence. The only time, and that would be important to remember, the only time you have reason to give Lasix is when you see activity accumulate in the pelvocalyceal collecting system. Do you see any here? You don't. No point giving Lasix. You do not wash out the tracer from the cortex by giving Lasix. So that's one of the reasons, I, for example, am not so keen on doing the types of examinations for obstruction versus no obstruction with the F- techniques. So F- techniques is when you give Lasix before you give the radiopharmaceutical. Obviously, you cannot predict this if you give the Lasix, say, 5 or 10 minutes before injecting the tracer. So you would give the radiopharmaceutical first and image first, and then knowing what that shows, you make a decision. At least that's how I have practiced and continue practicing today. It just makes common sense. So then the diuretic-induced polyuria is essentially your stress testing for dilated renal collecting system, differentiating non-obstructive from obstructive dilation. And washout rate is critically dependent, and you are dependent on that washout rate to make that differential. And that is entirely dependent on urine flow rate. That in turn is dependent on the dose of the diuretic, on patients' pre-hydration and continued hydration, on renal function, of course. Therefore, I would say that to offer trustworthy results, you must standardize all those variables. They should be standard. So if you don't have a standard approach to all that I've just mentioned, the diuretic dosage administration, the hydration, the making sure that everything is adjusted for the renal function, including the furosemide dose, then your results might be subject to those variabilities. Also, age was not mentioned, but it's a good time to mention it now, because most of the imaging for post-renal obstruction, in fact, is in young children. So we do children as early as some days after birth, not even a month, days. And for that, you have to remember that the term newborn has quite a low GFR. Therefore, your Lasix ought to be adjusted. In pediatrics, it is very well accepted that one administers 1 milligram per kilogram of body weight of furosemide. However, you also have to understand and adjust accordingly. As we said, you adjust for renal function in the preceding slide. That GFR is very low in term newborn. In the neonate, by day, it increases. And so we give 2 milligrams per kg in those who are newborn. At 1 to 2 months, it reaches about 69 or 70. And then that child would receive 1.5 milligrams per kg of Lasix for the challenge. And of course, at 6 months and after, it's pretty much the adult type of renal function. And then you go to 1 milligram per kg. You don't see that quite clearly explained in most of the textbooks. And I think that omission is significant to fill in. Let's look at case number 2. Indication was assessment of significant post-renal obstruction in view of bilateral hydronephrosis and left flank pain. That clinical history is 45-year-old, and as you can see, everything else is spelled out, had an IVP. And here is the first phase of the IVP. So you know that this is a study that was done a while back. We don't do IVPs as much or at all almost in some of the academic institutions. However, it does give you a nice holistic way of looking at the kidney clearance and accumulation of the agent or the contrast here. And as you can see here, at 45 minutes and post-void, there is a lot of the pharmaceutical or the contrast still in the kidneys. And that is all in the collecting system. So then, we have to really test this system for the obstruction. And as I've said, the important parts is we have to hydrate the patient with a specified volume for your facility. In our facility, it's done intravenously. And you have to report that, how you done it, how much you done it with. Then radiopharmaceutical, you have to specify that. And I would like to point out that our standard hydration is 15 mLs per kg. That is our pre-hydration. So we start and administer about 75% of that calculated volume before we start the imaging. And of course, as I've mentioned, we, as many, many others, do MAC3 imaging routinely. We usually do in 2 stages. First, dynamic stage without any intervention for 30 minutes, and then post-intervention, if intervention is required with Lasix. And then ours would be F of furosemide plus 30. Here are all the other options you have. Some give furosemide at the same time as they start the imaging. Some do it at 5 minutes, at 20 minutes. We give it at 30 minutes when the collecting system is fully filled with the radio tracer. That seems logically as the best time to challenge it, rather than when it's still filling and then you're worrying about what's coming in, what's coming out. That's a dynamic process. By 30 minutes, most of the tracer is cleared and collected within the collecting system. And that, in my view, is your best time to challenge it. So the dosage or the dose of furosemide varies. Some give 20 milligrams, standard, one size fit all. Some give 40, some give 60, some give one of those three, depending on some other factors. And so that creates some variability that it's hard to understand or explain. However, what you can also do, what we typically do, is give 1 milligram per kg as we do for pediatric patients. I typically limit it at 120 milligrams top administered dose. But we calculate with 1 milligram per kg. We do have some patients who are quite overweight, but the third spacing there is quite limited during the examination. And so I don't think that giving more than 120 really does do much good. But we do give calculated dose. That's how pharmaceuticals work. You have to calculate the dose based on weight. But as I've said, majority give a picked dose. You just pick depending on many factors that many of us would do very, very differently. And then you also have to think about, was the urine output measured? And if so, how and what was that urine output? We measure urine output in every patient for post-renal obstruction examination using Foley catheter, indwelling catheter. You cannot give a dose of furosemide of 1 milligram per kg, like 100 milligrams in a 100 kg person, without knowing how much comes out and how much to replace that person with. If you don't know that exactly, you're asking for trouble. So here are a couple of other procedure essentials. When you report, some patients actually come in with nephrostomy or some catheter already present, you need to specify in your report what you did. Was the nephrostomy tube clamped, unclamped? And that will depend on what the clinical question is, right? If they want to see whether the patient has now unobstructed after nephrostomy has been there for a while, well, you have to clamp it. Otherwise, you will be just testing the nephrostomy tube, and that might not be the clinical question. So measurements, always report differential renal function, always report post-Lasix T1/2. Those are the key points, at least in the way that we do our imaging, and other measurements as deemed important or pertinent to the case. If clearance is measured, you have to state the method and how you did it. So here's the patient. Again, the blood flow symmetrical, no particular significant findings. This is that same patient as I've shown you the IBP for. You see the same pattern, but dynamically. You see the activity symmetrically taken up. The cortices are intact. The axes are normal. And on a washout phase, urodynamic phase shows progression of activity within the pelvic calyceal system. On the left, less than on the right. On the right, it continues to accumulate. At the end of 30 minutes here, I would administer Lasix to challenge this collecting system. Let's see how they will do. And this is the calculated differential function, as I've mentioned, symmetric, all the other numbers. And you can see that the curves are not normal like you saw in the normal case before. So while the techniques vary, These are the most important parts. It's time of furosemide administration, as we mentioned. Dosage of furosemide is the key, and then hydration, and then urine drainage. Those are the key points. And you please do examine the International Scientific Committee on Radiopharmaceutical radionuclides in Nefrourology, and that's a ISCORN group. And that group, under the leadership of Dr. Tip Taylor, has produced a very good set of guidelines that can be pulled down from this website. I will send this to all of you so that you have that to click on. You also comment on the following findings. You always report the differential function, as we've mentioned, in whole numbers, describe relative size, shape of the kidneys, orientation. We already talked about qualitatively, describe the renogram, uptake, etc. Here is a very good drawing from an old article from 1992. Is going to turn 22 pretty soon, but still as pertinent as the first day it was drawn by Dr. Conway. Dr. Conway, since I believe retired, but this is a great legacy. I would encourage you to examine those patterns: normal, immature pattern, stasis or obstructive, or poor function, like this one, F. Many of these are quite useful to keep in mind. We will not going to go one by one through every one of them, but we'll demonstrate some. And here's what happens in that case number 2, returning after giving Lasix here. You can see that briskly, the left kidney completely clears collecting system, and the right kidney just as quickly. Let's process that. And we generate number of parameters, but the most important is the raw data from drop point, so from the point where this curve begins to drop precipitously, or what some call it inflection point. So drop point is 3.3 minutes, and then on the right side, it's 4.7. As I'm sure you all know, anything less than 10 minutes is non-obstructive. So this, although it looks pretty ominous on the IVP, it's a non-obstructive hydronephrosis. Here's again those numbers to keep in mind. If it's up to 10, it's non-obstructive. Greater than 10, but less than 15, probably non-obstructive. Follow-up in 6 months would be ordinarily recommended in our group. If it's greater than 15 but less than 20, it's probably obstructed, or at least might be heading towards obstruction, and you would like to follow that up in 2 to 3 months, little closer follow-up. And if it is 20 minutes or greater, it's obstructive. So again, some recommendations. State the patient's voided, how much the patient voided prior to the beginning of the study, how much voided at the conclusion, or how much was collected if it's collected drainage through the catheter, etc. And all of that is reported. All those parameters are reported in that at that website standardization that I've mentioned to you, developed initially by Tip Taylor and his colleagues. Also state the method of calculating T1/2. We typically report raw data count-based. I've shown you that on our page as it comes out of the processing. So raw data, just the counts, raw counts. You can also report linear fit or exponential fit, particularly if the raw counts do not drop to half of the peak activity by 30 minutes. We image post-Lasix for 30 minutes. So if it doesn't drop to half of its activity, you can't really calculate the T1/2, and you have to use then fit. We typically use exponential fit, not linear fit. It typically clears out as an exponent. In addition to T1/2, one can report some other indices such as output efficiency. We do not do that, or residual normalized residual activity, NORA. We also do not do that. We rely on half-time. But if you don't do a weight-adjusted LASIK imaging, post-LASIK imaging, then you may need to report those values, because it all contributes to then working out whether you think patient is or is not obstructed. You also, of course, will have to report all the clinical and measurements that you've collected. This is all also can be found in this article, Nuclear Medicine Communications article from 1998. You might want to review that if that's the form that you would like to follow. So with that, we're going to look at case number 3. This is a pediatric case, and as you can see, there is a first passive dynamic imaging. You got your initial image, that is your cortical phase. I highlighted that for you. I extracted it and enhanced it a little bit, and you can see that the axes here are tipped towards the midline. So the axis is tipped towards midline, and that typically you see in a horseshoe kidney. So you can see from the axes that it actually is not a normal kidney development. It's a horseshoe kidney. Subsequently, so the right side is not extracting as much as the left moiety, and then subsequent images demonstrate progressive accumulation of the tracer, more so on the right as compared to the left, but both do not clear. At that point, renal LASIK study is indicated, and I always explain why I do or don't do renal LASIK. So here is the differential function, 72% on the left and 28% on the right. And here is post-LASIK imaging. I would also point out to you that sometimes we try to make a lot out of these curves. And as you can see, this curve is downsloping, but so is the much lower right side that appears to be lower because it's not as functional, doesn't take up as much, but that too seems to be clearing. However, if you give LASIK, you notice that the right side essentially does not wash out much or anything, while the left side briskly clears within the first 4 to 6 minutes all of its activity. So with that, if you look at the raw data T1/2 from drop point, it's 1.7 minutes, so less than 2 minutes on the left side, and it's greater than 30 minutes on the right side. If you do a fitted exponential post-injection, it's 125 minutes. That's what it extrapolates to. So we do extrapolation when it doesn't drop to half of the peak activity during 30 minutes of observation. So post-LASIK clearance half-time, it's your surrogate for resistance to urine outflow. And as long as you keep that in mind, it is straightforward to understand what is a significant post-renal obstruction. So everyone has some resistance to renal outflow from the kidney. In those who are not obstructed, it could vary. But what does it mean when we say the kidney is obstructed? Does it mean none comes out of the kidney? It doesn't. A lot of folks, I think even some with considerable experience, I don't think explain it very well to those who are starting this business, if you will. What we really mean by significant postrenal obstruction is the resistance that raises back pressure to the cortex sufficient to result in functional damage over time. You essentially predict that this kidney, if left unchecked, will continue to lose function until it's pretty much all gone. So those are the ones that require intervention. It would be very easy and straightforward if when we meant obstruction, we meant just complete blockage. That, in fact, in real life, is not the case. And it's very important to understand this subtlety. Dr. Tip Taylor also has a certain way of processing using multiple variables that I've already pointed you to the group that he leads, and I would certainly encourage you to carefully examine their writings. But what Tip Taylor also says that T1/2 provides a single and superficially simple, maybe heuristic, to diagnose an obstructed kidney. That is, if T1/2 is greater than 20 minutes, the kidney is obstructed. So the current expert systems, so there are now computer expert systems that incorporate close to 116 different rules. And by incorporating all those, they can quantitatively determine parameters to distinguish between an obstructed and a non-obstructed kidney. But I would say that sounds, very encouraging. However, if you look at the literature, it has never been really proven conclusively with the gold standard of either watching patient, and of course that will be very difficult, right? No one wants to watch the patient lose the renal function, or Whitaker test is an invasive test that also is used for that. So our weight-adjusted rigorous diuresis also, I've checked on what the outputs that one would be expecting in those patients. And I've taken patients with variable creatinine clearances by estimated creatinine clearances, and our Lasix doses in our clinic in those 90 consecutive patients varied anywhere from 35.5 to 164 milligrams. So that's quite a lot. And the hydration volumes on average are about a liter. And they vary depending on the patient's size. As I've said, it's calculated anywhere from 400 to 2,500 mLs. The urine output is about the same, right? So the average is about the same. And you will always match the input and output before the patient leaves the clinic. But on average, I expect them to put out about a liter of fluid. And obviously, you can't do that comfortably without an indwelling Foley catheter. And in our particular facility, in that group, less than 10 was observed, T1/2, less than 10 was observed in 72% of all patients coming through. Greater than 20 was observed in 10%. So overall, 82% had a definitive answer. In about 15%, we had probably not obstructed, but probably ought to be then also checked in 6 months to see dynamics of it. If it's stable, fine. It's just a low-grade resistance that's not going to harm the kidney. However, in those who are greater than 15 but less than 20, only 3%. This is the group that you would like to watch closer. So with that being said, I don't know what you see in your clinical practice, but take a look at what you see in your clinical practice in a consecutive series. And if it's not quite as clear-cut, you might want to consider doing more robust imaging. To emphasize, almost all obstructions in nuclear medicine are partial. Complete ones are diagnosed by CT. They do not need our help there. They need our help to sort out unclear cases. A urodynamically significant partial obstruction is the one which will result in loss of renal function over time if left untreated. Key point: the mechanism of renal injury in obstruction are high pressure atrophy and infection proximal to the obstruction due to poor drainage. That's how we lose those kidneys, unfortunately. And maximum furosemide diuresis, input-output monitoring is essential, and at least in our facility, has been practiced for the past 35 years and practiced safely and gives you, in overwhelming majority, definitive results. So with that, I would only emphasize a couple of pitfalls that, as any good study, you will always have some pitfalls that you need to be aware of. Number one, very distended collecting system. You cannot really assess that for the reason that washout may be delayed, or even in non-obstructed system is just too large of a volume to apply the principle of tracer dynamics. In that kind of situation, you would consider an invasive test called Whitaker test. Whitaker test involves putting actual nephrostomy tube and measuring the pressures as you increase the flow rate. And in the constant flow rate, there is a threshold back pressure that would indicate significant obstruction. Our T1/2 is a surrogate of that back pressure. Very impaired renal function, obviously, if you cannot generate response to Lasix, you cannot test it. That again leads you to the Whitaker test. You don't really have much to offer to that population. As I mentioned, when do you know that? Well, you know that when you look at the initial uptake or cortical phase imaging. If the cortical extraction of MAC3 is poor, your Lasix will work poorly. We don't have a sophisticated way of adjusting Lasix dose according to the renal function, and probably something in the future that we would need to focus on. And of course, in infants, there is a poor response to furosemide. We already went over that, and I showed you how it gets to almost a adult function by 6 months. But before that, you can have a poor response to furosemide. So here's a couple of cases for you to take home. A 20-year-old college student with intermittent left flank pain evaluated for significant postrenal obstruction. Here's the renal flow, nothing special. Again, not much information there except it's symmetric. Here is the first uptake, cortex, perfect. Washout, some residual activity in the left, most of it clears from the right. So Lasix is appropriate here. Some might want to do, from laying down, sitting up, and see post-void, but be careful doing that, because in those young adults, there is an interesting phenomenon, and we will see that in just a minute. Here's the differential renal function that's better on the left, or more on the left than it is on the right. So on the side that retained, there is a greater function that kind of would raise your eyebrows like, I wonder why that is. And the curves aren't terribly abnormal, right? Everything is downsloping. But this is what happens after you give Lasix. Look at this system. At some point, it begins to enlarge, balloon out. And then the cortex that nearly washed out, you see a backflash of activity back into the cortex. See that? So what is that? And here is the curve, initially downsloping, and then boom, upsloping, upsloping. while on the right side, it's a precipitous drop. So what would you call that? Think about it. What is your diagnosis? It's a high flow rate dependent obstruction, typical for young adults, and they usually have like a six-pack or some large volume when they start feeling that flank pain. So you can't just do this maneuver of having them stand up and see if it drains. It will drain, and you will miss the ball altogether. You need to give Lasix. So we have maybe a couple more minutes left. 35-year-old male, status post-renal transplant with multiple medical problems, developed rising creatinine. However, on the biopsy, they didn't see any significant rejection. So they were wondering, is there post-renal obstruction? And the collecting system did appear on ultrasound prominent. Here is the blood flow. And of course, in a renal transplant, you see some blood flow in the renal transplant position, and it's not a great flow, but maybe not a great bolus. It was through some kind of a long tube. Extraction is expectedly poor in the renal transplant here, so it's a aged renal transplant, and we see the tracer taken up, gradually collecting in pelvic-calyceal system, right? And not so much draining. The patient is drained by indwelling catheter, as you know, that's how we do it. So is it obstructed? Is it not obstructed? You need Lasix. So here is what the curve looks like. So that's a pretty typical curve where you would start worrying about obstruction. Pre-Lasix, that's all pre-Lasix. So let's do the post-Lasix. Here is Lasix given. Well, isn't that interesting? So here you have outline of the kidney, and you see the T1/2 of 34. So that's greater than 20. Is that obstructed? Take a close look and think, would you call that obstructed? And I'm sure you're probably saying, no, I don't think I would call that obstructed because I see that the collecting system actually clears. What's left behind is just the cortex. Exactly. So when you have patient with renal dysfunction, and this is just a renal transplant case, but would be the same in patients with both kidneys still working, you have to tightly outline the collecting system and then bring the background region of interest such that you correct for the true background. Remember that behind that collecting system is that same very kidney contributing to the counts. So you need to be nice and snug, but not including the collecting system, and then redo your T1/2, and it's only 8 minutes. So if you do it right, you get the right result. In conclusion, maximum diuresis is the stress test for accurate diagnosis of significant post-renal obstruction. Control of key determinants for diuresis, such as effective Lasix dose, hydration, renal function, are paramount in offering a reliable test. Clinical reliability of post-Lasix T1/2 rests entirely on optimizing and controlling of those key determinants for maximum diuresis. With that, I'll be more than happy to take some questions, and I will give the podium back to the moderator.
Thank you so much. That was very well organized and very clear cut for all of us. Excellent review. We have about 7 questions. Delisha, are you able to stay on about less than 10 minutes still to keep the session open?
Absolutely.
Okay, so we'll go through what we can. The first one is, please review location of regions for background correction. And we did have a response to that. It said crescent background, region of interest. Is it enough to go up until half the kidney as the figure shown? I usually go into a half external crescent, including liver and spleen, to allow its background activity to be corrected also. That's two questions.
Right. Makes sense. Right. It is reasonable to include if there is significant contribution by liver and spleen. That's very reasonable. However, unless you are doing it to derive some functional parameters, probably not important, because it's for the curve generation, right? So curve only gives you general impression of the urodynamics. When you do it for the differential renal function, that's where it's important. Then you would do circumferential, not crescent, circumferential. And that, by definition, will outline the most closest to the kidney parenchyma background, skipping only the area of the renal hilum, pretty much. So that in the renal hilum, there is no particular background, really. So that is the best method if you're talking about differential function. Two backgrounds for two different purposes. One, for calculation of differential renal function, you do it circumferential. For curve generation, it's crescent. And the crescent could be variable. Again, that curve is not something that we do much of impactful calculations on. I hope that clears it.
Yes. Next question is, using the F+30 approach, do you have the text present the images to the attending nuclear medicine physician prior to Lasix administration to ensure there is activity beyond the parenchyma?
That's a perfect question. I should have included that, and I will next time for sure. That's very important. It is a decision point for the physician. So technologists would bring the image set or would call the attending to review the images. Usually it's done nowadays online, right? So no one has to really use the sneaker net. We can use the Ethernet to call. It takes a few minutes and make a decision. Those are consequential decisions that are based on physicians knowing the clinical history, the specific clinical question, and would still be within the realm of the physician to make the final call and determination. Very important question. Thank you.
Okay. If the patient is administered diuretics chronically, do you recommend stopping those beforehand? And if so, how long before?
Also a good question. Typically, we do not necessarily ask them to stop beforehand because we're going to prehydrate them. As I've mentioned, we have a standard prehydration. I have not included the image that I have from another institution where the patient was called obstructed, and the only reason on our repeat was that they were not well hydrated. And I do believe that that patient was on a diuretic. And just, you cannot, you cannot squeeze much juice out of a dried raisin. It's just, that's not the way to get the flow out. So you cannot really challenge a patient who is dehydrated. You will never get an appropriate result or usable result.
Can a diagnosis?
Yeah, we don't, just to finalize, we do not call and tell them how long to stay off of diuretic. We prehydrate them with our usual hydration protocol that encompasses all comers, and they will restore the volume in all, and then challenge them and follow their ins and outs. So in our system, it's probably not as relevant as in many others who do not do the IV prehydration.
Next question is, can a diagnosis of obstruction be made from a single study?
Well, So I suppose if the study is IV-enhanced CT, and it's a clear cut, and particularly if you see the point of obstruction, that really is all you need. But that is, and probably Twyla, you can comment on it more comprehensively than I can, because you see, all variable studies. I don't know how often you would be certain to say that it's definitely obstructed, but I do believe if you see a stone wedged and and a contrast accumulating up to the point of presumed obstruction, you can be fairly reasonably sure. But frankly, that's a small portion. Majority of patients who do not get functional LASIK study, the physicians simply make a guess, or they assume. And I don't have to remind you what happens sometimes with those who assume. It's probably not a good system for use in medicine.
Okay, next question is when will you use the term impaired renal drainage?
Impaired renal drainage. I never used that term. We have, the LASIK renal study is a quantitative study, and that defines how impaired it is or not. And I use those predefined statements. I try not to craft verbiage that might not be standard. So I don't use that.
Okay, next question. In your practice, is a Foley always administered for adequate IO assessment?
Yes.
That was an easy one. Next one, do you use change of position in very dilated systems, supine, erect, supine, to see if there is drainage after position change?
Okay, so that only applies to pediatric population. And typically in pediatric population, there is a positional obstruction in some children. When they are prone, they drain, and when they're supine, they obstruct. So that's a very specific condition. However, you cannot keep children prone all the time. And some would say that changing position, although you do demonstrate what the dynamic is, might be redundant, because no one is going to keep their child always prone. In fact, it's considered to be not very healthy position. So one way or the other, that needs to be corrected. If someone likes to see that just for physiological, if you will, eye candy in a sense, sure, one can do it. We have done it. We have done it for years initially, but then recognizing that it doesn't have any clinical consequence, showing it, that will still need to be corrected. I'm usually satisfied with just seeing a supine.
We have two more. One more was added. So these will be the last ones. Should you give LASIK in all cases of hydronephrosis?
No. There are multiple cases of hydronephrosis, which I have not shown it to you here at this particular slideshow, that will demonstrate brisk clearance with our standard prehydration. Because our standard prehydration, as you know, is 15 cc's per kg over about 20 minutes. It's a pretty brisk rehydration, and could induce quite a bit of diuresis. That flushes those insignificant ones out. And I've had many that we would discharge without having to proceed with LASIK. So the answer is no, not everyone. And that's why it's important to see those images before technologists or your maybe nurse practitioner administers that challenge, because it's a considerable challenge of Lasix, at least in our clinic it is. And every one of them will be, will be okayed and actually signed for by a physician.
Okay, and this appears more like a comment. It's the last item here. Follow-up differential diagnosis of obstructive versus non-obstructive hydronephrosis. Maybe they just want you to comment on that.
Say it again now. I'm sorry. Follow-up, what was that?
It says follow-up differential diagnosis of obstructive versus non-obstructive hydronephrosis. Maybe they're asking, how do you follow up?
Yeah. No, I suppose the differential diagnosis may be the key point here. And I would say that, it's, for example, could it be a crossing blood vessel, particularly in pediatrics? Could it be a kinked ureter proximally? So there are multiple reasons, and that would be determined by anatomical imaging. We do not guide that part just because our anatomical determination is just not there to be used. But there are multiple actual causes and reasons for obstruction. Sometimes you have intrarenal cysts that obstruct, right? Occasionally, close to the hilum, exophytic cysts in the elder patients can obstruct, et cetera, et cetera. So the list is probably endless, but we do not typically provide much in terms of that, except we do tell them when we can see it if there is a point of obstruction, and sometimes it takes a delayed image. For example, I showed you that cortical retention. In that cortical retention, when we took an image at about 16 hours post-injection, all the tracer has collected to the point of obstruction. And that is not something that is often doable by other techniques, but sometimes you can indicate where the point of obstruction or transition is. Well, those were fantastic questions. The last but not least one was really quite pointed and reveals our bit of a some weakness on the side of functional images is we don't have a good anatomy to go along with it. It's unlike with fusion imaging, where we do have some anatomical modality to go along with it. In these patients, we do pure functional testing, and especially in children, we typically don't add much of conjoint anatomical imaging that usually would imply some additional radiation exposure, unless you were to use an ultrasound. So I thank you so much for being and spending this hour with us. It was very enjoyable, and I hope you take some points home with you and review what I've presented at your leisure. And we will see you next time when we have a next webinar. Thank you very much, Twyla, for this great moderation. I appreciate it.
Likewise, thank you so much for this great talk. It was very appreciated. Thank you, everyone, for attending.
Thank you. This concludes today's webinar.
¿Le diste la tarjetita de descuento de la Toyota? Ahora se la doy yo. Me pidió no me sale el nombre. Sí, el librito. El librito. Aparte de la tarjeta de descuento. Ahora que yo te dije. No. 10% de descuento con cada service. El Alzheimer. ¿Dónde está el auto? Con la llave. Lo que hice fue sacar la cosa negra de atrás. El piso negro de atrás. Creo que eso es lo que sigue oliendo en nafta, así que lo voy a lavar otra vez. Sí, no lo dejé en el auto. Ya no hay más. Pues yo no compré ayer porque quesos hay un montón. No compré porque quesos hay un montón. ¿Dónde está el barbijo? Acá hay un...